Hello, everybody. Can you see my screen?
Yes, we can.
Okay. All right. My name is Salmaan Jawaid. It's an honor. Thank you for having all of us, especially me, on. Okay. Sorry, it's running on autopilot. I want to talk a little bit about esophageal POEM and GPOEM as an alternative to surgery. As we know, for achalasia, the mainstays of therapy are Botox, pneumatic balloon dilation, the traditional surgical myotomy, and now POEM. Really briefly on Botox, we all know that it's effective in the short term, but not effective, not durable in the long term. So really used as a transient therapy. For instance, a patient needs to get out of the hospital and so forth. So not the first line of therapy unless there's an emergency need for therapy. Pneumatic balloon dilation is effective, but has risk of perforation of 2.8% because it is relatively uncontrolled, even though it is in a controlled setting, if you will. The muscle fibers are sheared here, but they're not entirely sheared. And this is why you can have recurrence within 3 to 5 years. So effective, but also not very durable. And I would consider this less safe. Now, Heller myotomy. This is your traditional approach, very, very effective.
Dr. Jawaid?
Yes.
Would you please expand your slide from make it a full screen?
Oh, I apologize.
Okay. No problem.
Actually, it is the one that have full presentation, Salman, I think. Number 2 from your right side.
Yeah, how do I?
At display settings, if you swap it, that might work.
That'll work, yeah. Okay, all right, sorry about that. So Heller myotomy, traditional response where they go through an anterior approach and they cut the muscle. This is limited because it works for type 1, type 2, because we can cut essentially 6 to 8 centimeters, but if you need to go more proximal, this is more challenging. But nevertheless, very effective. Studies showed about 88 to 95% response rate, and even in midterm follow-ups, pretty robust response. The main benefit of Heller myotomy was while the surgeons were there, they would also create a wrap. As we know, there's about 40 to 50% increased risk of reflux after myotomy. So that was a benefit. You get 2 in 1. But keep in mind that a wrap isn't always needed. And so half the patients may undergo a wrap that would not have been needed in the first place. And the most important part of the Heller myotomy, although very effective, it is invasive, right? It's a surgery. And in the day and age where we're going towards less invasive approaches, patients have longer hospital stays and it's painful, but nevertheless effective. But because of the invasive nature and some patients who aren't good surgical candidates, a less invasive option was needed. So this is the development of POEM, which is essentially an offshoot of the concept of notes, and it's been revolutionary in the way we manage conditions that were previously treated only as from surgical approaches, and has really changed endoscopic surgery in a whole. So really quickly, a video of it. Mucosal incision here. You access the tunnel, submucosal dissection. This is the muscle fibers here. You see that? You go all the way down to the LES. And you can confirm injectate goes through the LES into the cardia. That's how you know you've been you're far enough. You also will see palisades vessels and spindle vessels of the cardia lumen right there. And then ultimately you start dissecting the muscle right here. And if you go through an anterior approach, you'll see the heart there. Go all the way down. You can do a full thickness all the way through, which is what we prefer here, or partial thickness proximally, and then full thickness at least 6 centimeters to the LES. Once this is complete, you come out and close the mucosal incision, which is the most important aspect of this procedure and what makes this procedure possible. And this is similar in GPOEM as well. And close the edges, and the patients recover very nicely. So what does the data support for POEM? Very effective, 98%, and immediate follow-up, long-term follow-up still maintains a robust response. The safety profile is excellent, very low risk of complications. Patients, we admit all patients and they usually go home the next day. Pain is much less common. And the benefit of POEM is in type 3 achalasia, you can direct a longer segment of myotomy, which is more favorable than compared to surgical myotomy, which you can only direct to 6 to 8 centimeter. When you look at comparative studies, clinical response rates are similar. Adverse events are higher in Laparoscopic myotomy. Despite the longer length of myotomy in the POEM, the procedure time is significantly less, 100 minutes. Really, if you look at expert time, it's under 60 minutes. So much less, it's a quicker procedure. If you look at all types, type 3 is where you have the real advantage of POEM because you can direct the longer myotomy. And then even in spastic conditions, you can perform POEM, and it's actually quite effective for jackhammers and diffuse esophageal spasms. So what's the issue? Why is it still not fully adopted? We know POEM is equal, if not more efficacious in the myotomy, better for type 3, shorter procedure times, less pain. You can direct any kind of therapy, very flexible in terms of approach. The issue lies in reflux, and we know with POEM, there's no wrap. So almost 40% of patients will develop some sort of abnormal acid exposure. However, we do know that majority of these patients are easily managed with medications or can undergo endoscopic TIF or undergo a wrap, a surgical wrap, if you will. So the POEM does not preclude you from further surgical therapy for acid reflux. So, so when you have patients with achalasia, I really would advise for type 1, type 2, discuss the risk of reflux, and if they're okay with understanding that the incidence of reflux post achalasia, post POEM, would really favor POEM, but you can still offer surgical myotomy if they prefer. It really comes down to the issue of acid reflux, and as long as they understand that. For type 3, most experts will recommend POEM because you can direct the therapy. So, final consensus is that it's less invasive for achalasia. It's less invasive and equally as effective. So we would favor POEM as long as patients understand the incidence of reflux and how to manage that. Switching gears a little bit to gastroparesis, a similar mechanism, but not entirely to achalasia. It involves loss of antral contractility and high amplitude pyloric contractions. These are the mainstays of therapy. We all know. We know dietary changes are effective for all treatment conditions, regardless of which ones we choose, but about a third of patients will still not respond. Pharmacotherapy is effective, but it does have undesirable side effects, as we all know, and it's not great for the long term. Botox, similar, not very durable. Gastric stimulators have variable response. It's difficult to find people who would put places or manage them. And it's not really durable for idiopathic or post-surgical gastroparesis. So when you look at GPOEM individually, clinical success is 100%, very low rate of adverse events, 25% decrease in the amount of retained food after GPOEM. And on subjective and objective testing, the response rates are quite robust. And even when you look at quality of life scores, almost three-fourths of patients a 16-month follow-up report significant quality of life improvement, significant reduction in ER visits, hospitalizations, anti-emetic use. And when you look at specific breakdown of subtypes, idiopathic GPOEM is very effective, 90%, and also for post-operative. These are the two patient category of patients who respond reliably. Diabetics are less so, but still worth a try. Surgical pyloromyotomy, very effective as well. Clinical success rates are also very similar. The main difference is that it's invasive, it's painful, but the adverse events rates are higher. So not very many studies looking at both head-to-head, but the ones that have been reported here, similar technical and clinical efficacy. But in this first study about POA, from all objective parameters, GPOEM actually was more favorable. It has lower procedural times, 20-minute difference, lower hospital and length of stay, and a lower complication rate. So ultimately, this is showing right here the pyloric ring and the cutting of the muscle. Obviously, long-term studies are needed between both treatment options, but we know, at least from preliminary data and anecdotal evidence now, GPOEM is less invasive and safer than surgical pyloromyotomy, and at least equally efficacious. So this, most experts will now consider G. coli to be the first line of treatment in patients with refractory gastroparesis. Thank you for your time. Hopefully this was helpful.
Thank you, Dr.